Okay, welcome to this week's Journal Club. We are going to be discussing a paper by Castrogiovanni and colleagues entitled Longitudinal Changes in Cognitive Test Scores in Patients with Relapsing, Remitting Multiple Sclerosis, an analysis of the DECIDE dataset. I'm Dr. Vicki Leavitt. I'm a neuropsychologist and cognitive neuroscience researcher at Columbia University in New York City. And I'm joined today by Dr. Laura Hancock, who I would like to invite to introduce herself at this point.
Hi, I am also a clinical neuropsychologist and researcher at the Cleveland Clinic.
Thanks, Laura, for joining me. And also, we'd like to, both of us, thank the American Academy of Neurology for inviting us. We are super excited about this topic. I know that both of us are quite passionate about today's topic, and I'll jump right in. So as you heard in the title of this paper, the clinical population that we'll be discussing is multiple sclerosis. Multiple sclerosis is the most common non-traumatic cause of disability in adults. It affects 2.8 million people worldwide. It is an incurable disease of the central nervous system, involving diffusely dispersed lesions of the brain and spinal cord, as well as neurodegeneration. MS can involve symptoms affecting virtually any neurological systems. So it can involve mobility impairments, it can involve fatigue, depression and anxiety. It can also involve cognitive impairment. And cognitive impairment is one of the symptoms that, although it can be debilitating and disabling for people even early in their disease course, it's only been recognized as a key symptom of MS in really the last 30 years. And I'm going to share a slide right now with all of us to kind of mark the beginning of when we started to acknowledge the importance of cognitive symptoms in MS. This was a paper published by Steve Rayo, who's actually at the Cleveland Clinic with Laura and colleagues. And this paper came out in 1991, and it was one of two companion papers published in the journal Neurology that really highlighted cognitive impairment in MS and described and characterized how cognitive impairment looks, sort of prevalence patterns, what domains are affected. And many of the observations that Steve and his colleagues made still hold true today. So it's kind of it sets the stage for where we've come in that time. And we've come a long way to the point where we now have studies of disease-modifying therapies of MS clinical trials, which incorporate cognition as a secondary outcome. This is very common, and it will bring us to the paper that Laura and I are going to discuss today. Before we get there, however, I want to frame our conversation with this next slide that I'm going to share, just so that we all kind of remember and keep in mind how cognition looks across the adult lifespan for everybody. So this is one such figure that I chose of many. This was from Tim Salthouse, published in 2006, looking at cognitive reference abilities, he termed these. And it just highlights that for all of us, cognition is declining over the life course, by and large. You'll see here that the one area where we sort of stand to maintain is vocabulary, right? We can always gain more words over the lifespan. But beyond that, cognition is declining for all of us. And this is something that I want to highlight and for us to keep in mind, and we'll touch on it later in our conversation. The other thing that I want to just mention and go back to is that DMT trials are incorporating cognition as a secondary outcome. And that was very nicely reviewed in a systematic review and meta-analysis by Nils Landmeyer and colleagues in a paper also published here in the journal Neurology in 2020. What they did was they did a meta-analysis of 41 studies that had incorporated cognition as a secondary outcome. And they found a small to moderate improvement in cognition in the trial, in the treatment arm of all of these trials. So these are the pieces of information that I want to lay forth to set the stage for the discussion that Laura and I are going to have of today's paper. Let me go ahead and introduce the paper now with no further ado and give us a quick overview of what the authors found. So the study that Castrogiovanni and colleagues published is a retrospective analysis of data from the DECIDE trial, which compared subcutaneous teclistamab to intramuscular interferon beta 1A in 1,814 patients with relapsing remitting MS. Two cognitive measures were evaluated: the symbol-digit modalities test, the SDMT, which tends to be considered the best and most commonly employed cognitive test for MS, and the PASAT, which has been discouraged as a measure for use in MS mainly because of how intolerable it is for patients, and also because it's confounded in several ways, including mathability. So patients in both treatment arms showed steady performance improvements across up to 6 time points of data from baseline to 144-week follow-up on both cognitive tests. For SDMT, the mean improvement was 4.9 points, and for PASAT, it was 3.3 points. Now, importantly, the percentage of patients showing improvement was consistent across several different definitions of clinically meaningful change, and this was a nice methodological consideration that the authors made. They incorporated 4-point change, 8-point change, and 20% improvement for SDMT. And on PASAT, they looked at 4-point change and 20% improvement. These improvements were observed consistently in the context of an overall decline that the sample showed in performance on the timed 25-foot walk test, a gold standard measure of mobility, which steadily worsened over the same follow-up periods. What this suggests, and what the authors concluded, is that practice effects were responsible for the improvement seen in cognition. Laura is going to talk about practice effects and what that means and so forth. But before she does, I just want to sort of wrap up this discussion of the Castrogiovanni study per se, by noting that the authors made another conclusion, which was that more research may be needed on SDMT and PASAT to inform recommendations for a threshold indicating clinically meaningful change. And I want to make what might be sort of a bold counter conclusion, which is that perhaps no further research is needed on SDMT and PASAT. And what instead we need to be thinking about is that these measures may be too susceptible to practice effects to yield biologically plausible measurements of cognitive change over time. So before we get into that, I'm going to go ahead and invite Laura to explain some of the key concepts that I touched on from the Castrogiovanni paper, central of which is the practice effects.
Yeah, that biggest one is practice effect. And that's something you and I think about every day in our jobs. But if you're not a neuropsychologist, you might not be thinking about that and wondering what it is. So essentially, it's improvement in performance as a function of having previously taken that test or performed that task. So basically, we expect performance to improve on subsequent administrations. So the second time a test is taken, the third or fourth time a test is taken, the person is going to benefit from the experience of having taken it previously. So this is an important consideration when we're talking about trying to measure clinically meaningful change and trying to measure intervention effect or treatment effect. And this phenomenon is not isolated to cognitive tests. You can imagine the first time you ever were exposed to the Rubik's Cube, for example. You'd never seen it before. You maybe never saw a game or a concept like that before. And the second time you played with a Rubik's Cube or attempted a Rubik's Cube, your performance benefited from that first exposure. The 10th time you tried to pick up a Rubik's Cube, you benefited from those prior exposures because you've learned something from those prior exposures. So practice effect is not necessarily the same for each individual. Lots of other factors in addition to practice effect or learning effect can influence cognitive test performance and the accuracy with which we measure cognition. Unfortunately, the measurement of human behavior is not as straightforward as the measurement of metabolic functioning, for example. So we have to consider all of these potential sources of error, with practice effect being one of them, as we are designing our studies and also interpreting the results, of course. And that's why the authors and also you, Vicky, have pointed out concerns related to the conclusions from the DECIDE study that we need to be perhaps cautious in our interpretation of these improved scores that were consistently improving across the course of the study.
Which, by the way, if I can interrupt for a second, Laura, um, it sounds like a detail maybe to people who don't study cognition in multiple sclerosis, but what we're saying, I mean, the findings of this paper are disturbing on one level, right? We want people to be concerned with cognition in their patients with MS. We don't want
We
people to
absolutely
say,
do.
yeah, and so we have to be careful about how we talk about the flaws of our measurement instruments. All measurement instruments have flaws, and all measurement instruments can be made better, but we don't want to throw out the baby with the bathwater. We don't want to
No,
discourage
absolutely
people
not.
from focusing on cognition.
Absolutely not. I'm just trying to provide a framework for people to understand why, as a profession, we are very concerned with accurate measurement and trying to make sure that we are drawing the right conclusions.
Mm-hmm. And
Um,
knowing what those sources are. So I'll let you go ahead and plunge into more.
yeah. Well, so other potential sources of error include things like how well a person slept the night before the evaluation, how well the examiner slept the night before the evaluation. There are lots of potential factors in that equation. But that said, we have developed better tools over time. We have better tools now than we did 30 years ago, than we did 50 years ago. We've better studied those tools to understand them, and we have potential strategies for mitigation. So kind of jumping ahead a little bit, uh, there are some researchers who have suggested, well, we can more accurately measure practice effect and determine whether that might actually help us measure intervention effect. And we can better use a formula like a reliable change index in order to determine for a particular population of people if you have an appropriate reference population and the practice effect in that population, then we can try to estimate, all right, well, how much of this improvement is practice effect and how much of this improvement is actually intervention effect. So it's not all just one or the other. It's a mixture. And you know, it does raise, I think, important questions about sort of how we go about this. And, are we going to go down the path of developing new and better tools, which I would argue we should. And I think you would agree with that. But we can also maybe take a different approach to this measurement at the same time so that we are coming at it from two different sides.
Yeah, I think you raise a lot of good points, Laura. And I think to myself, well, a neurologist listening to this might be thinking, oh my gosh, what am I going to do now? Like, should I keep collecting SDMT from all my patients? And what would you say to that neurologist?
I would say yes, but I think we should be wise about how often we collect that measurement in order to try to minimize practice effect and to keep as you said in the beginning, the SDMT is probably the number one respected and well-regarded measurement tool in MS, but also in some other disease groups too. And it's very useful in practicality because of how brief it is and how easy it is for someone who maybe doesn't have a lot of experience in administering cognitive tests to administer correctly. So I don't think we're going to get away from that because there is such a history of rich data there. And I don't know that we necessarily should get away from it, but we probably shouldn't be giving it every month in clinical care or every 3 months in clinical care. We should be using it a little more sparingly than that in order to try to improve the accuracy of the measurement.
For
What do
myself,
you think?
honestly, I like to think of the SDMT as a screener. And I think it's a great screener. As you mentioned, it's quick and easy. For people who don't know, it takes 90 seconds to administer, and you administer it with paper and pencil. So you don't need any fancy gadgets. You don't need anything other than a table. Not even
And
that.
there is an iPad version if you want. If you need that convenience, there's
Yeah.
also an iPad administered version.
But with regards to what to do with a change score over time, that's where
Mm.
I start to encounter difficulty myself. And what I think for me, again, the usefulness of the SDMT as a screener is it tells me if somebody's impaired. It doesn't tell me why they're impaired. And so it indicates that we need to go further. Now, the other thing, Laura, I think I would love to talk to you about is ground truth. Like, how do we know that a patient actually has cognitive issues? And for me, ground truth is when a patient says, I have cognitive issues,
Yeah.
and they have begun since being diagnosed with MS. So for me, that's my starting point. And then I use my tools to try to figure out what it is specifically, because patients don't generally sit down and say something like, I have a lexical retrieval deficit, right? They don't
Right.
say that. They don't present that way. They present and they say something like, I have cog fog. And then you have to say, well, what does that mean for you? Or where did you pick up that term? I saw it in a podcast from the MS Society. So
Absolutely.
we're like little, investigators who have
Detectives.
detectives who have to sniff out what's actually going on. So,
Well, I would agree with you. I think we should take what patients tell us as ground truth and do the best investigation we can to find the mechanism and to find the weaknesses and the strengths so we can use someone's strengths to their advantage in trying to mitigate those weaknesses. But I think the other, sort of related issue here is what is meaningful change
mm,
in the real world?
right.
So there have been a couple of research groups who have looked at, is it a 2-point change on the SDMT? Is it a 4.8-point change or 20% as this paper investigated? What is clinically meaningful change? And I think that is going to vary by person. I don't think it is so universal that we can just establish one cutoff for everyone. I don't know
Well,
what you think
right.
about that.
And we need real world anchors, which is something
We
else
do, we do,
talk
because
about.
if someone improved 2 points
Mhm,
on the SDMT, for example, how does their life look different?
mhm, mhm.
If
Or if
they're
they declined, right?
right,
Maybe
or if it's a
more
2-point
importantly.
decline, how does their
Yeah,
life look different?
yeah.
And if it's a 2-point decline from a very high score to a less high score,
Mhm,
that change is going to be perceived very differently than someone who declines 2 points and they're still well within the average range or
mhm.
well within the low average range, for example. So, and kind of going back to what you said about the ground truth is what people tell us. So we need to listen to what people are telling us about changes that they're noticing in their life that are diminishing the quality of their life
Mhm.
so that we can intervene and intervene early.
Yeah. And Laura, I think the really tricky thing in MS is that these folks, on average, MS is diagnosed at age 32. So these folks are young, they're in the prime of life. I had a patient 2 days ago who was an MD PhD, recently diagnosed, and he was asking me about clinically meaningful change and what does it look like and what should he expect and when should he come back for a follow-up cognitive evaluation. And we got talking, and I said, the MS literature has looked at real life anchors like loss of employment. Clearly, that's a very coarse anchor, and we don't want that's
We
not
don't
what
want it to get to that point before
we
we
don't
say,
want it
oh,
to get
look,
to there.
now this is a problem.
But we know that there are other points along the way, which
Yeah.
is somebody who's very, very high functioning coming in and saying, well, this week I feel like I'm only very high functioning. So it's this particular clinical population represents a unique challenge for neuropsychologists because we're not looking for, do you have dementia or do you not? We're looking for, are you very, very superior today or are you only very superior? So I think we really need to work to develop much more sensitive measurement instruments than the field has or has ever had.
Yeah. And I think another point to your main point there is the disease duration. We're not talking about a disease that a person lives with for 5 years at the end of their life when they're no longer working, when they're no longer caring for children, when life is very different. Not that that is insignificant, because it's not. But when you're talking about getting diagnosed at age 32, and we know people with MS are living much longer lives than they used to, in part because of the improved access to DMTs, the more greater number of choices for DMTs. But if that person is going to live until 82, they're going to have MS that whole time, unless we develop a cure before then. So how can we manage a change that happens at age 32 to help them live a full life and help them engage in the things that are important to them for the duration of the time that they want to do it? And so to me, that also means that we need to be doing early intervention, having maybe more precise tools, more sensitive tools that can detect this change, meaningful change, but then also developing intervention strategies that can help people sustain, or maybe even prophylactically treat any cognitive weaknesses, to help sort of shore things up, to help them maintain those skills across their lifespan.
I completely agree. And maybe just to kind of wrap up and bring it back to the Castrogiovanni study itself, I think that right now our best avenue for delaying cognitive decline is DMTs. And so incorporating cognition as not only a secondary outcome, but perhaps down the line, a primary outcome of these studies, and incorporating newer, superior measurement instruments that are more sensitive and specific could be a really promising direction for the future. So I think we can wrap up there. Laura, what were your final thoughts?
Oh, I was just going to agree with you. And I think the direction the field is going with including cognition even as a tertiary endpoint, I think is a really, this is the direction that we should be going. And this is a big problem that people with MS deal with. And until very recently, we have not had the sort of evidence to support the belief that many of us have that DMTs actually do help at least prevent cognitive change. And it'd be nice to have some data to back that up. And I think we can get there if we go about it the right way, as you said.
Great. Thank you so much. And everybody who tuned in, we appreciate it. And thanks again to the American Academy of Neurology.